Welcome back to Rural Health Today. This episode is another installment in our season on maternal care and rural health, where we're talking with maternal health experts about rural maternal morbidity, genetics, mental health, and more to understand the barriers to proper maternal health care in rural America. I'm excited to introduce our guest today, a friend of Hillsdale Hospital, certainly no stranger, someone that we have leaned on for statistical information, for research information, and really just overall knowledgeable guy about payment reform. And we're living in an industry today in healthcare where it's all about payment reform. It's about payment in general. It's about quality, marrying the two. And so I am pleased again to introduce to our audience Harold Miller, President and Chief Executive Officer of the Center for Healthcare Quality and Payment Reform. Harold, it's been a while since we've had this opportunity to come together. And last time I had a co-host with me, Rachel, and we talked about some very exciting, very sobering issues. But today we're going to talk a little bit something about a narrowed niche that hospitals are either all in or all out. And I want to talk to you a little bit about that. But before we do, for those that may not know you or have heard your podcast before, I'd really like for you to talk a little bit about your role at the center and, what are you doing in that role and what is the center doing?
Well, first of all, it's nice to be back, and thank you for inviting me, and thank you for doing all of this work to try to bring greater attention and visibility and knowledge to the issues associated with rural healthcare. I run the Center for Healthcare Quality and Payment Reform. I started it almost 20 years ago because of a recognition that in many cases, things that physicians and hospitals wanted to do to be able to improve the quality of care for patients, they couldn't do because they couldn't get adequately paid for it, or they would actually lose money by delivering better quality healthcare. And the payment system is a major barrier in many cases to delivering high quality healthcare. So that's where the idea for the Center for Healthcare Quality and Payment Reform came about. And rural healthcare is particularly disadvantaged by that because the payment system in many cases really does not support delivery of good quality healthcare in rural areas, even when it does in urban areas.
Yeah, and I often quote Harold Miller when I'm in Washington or when I'm in Lansing, and the work that you've done to bring forward some of these issues has really helped rural hospitals like Hillsdale to be able to tell our story and to be able to use information that is so valuable to present to our elected officials. And you've done a tremendous job at uplifting some of the issues that are most important to us.
I'm glad it's been helpful. Thank you.
Absolutely. So today, if you're tuning in, we are talking about access to maternal healthcare services and resources specific to rural areas. We often talk about how many rural hospitals have closed in the last decade. We focus on that number now reaching 160 to 165 in the last decade. But the deterioration of birthing centers and maternity services is even more shocking. Every day I hear a story of a hospital that has closed their obstetrics unit. And there's often talking points associated with that. Those talking points range from, well, we're going to give better healthcare outcomes because they can go to a larger center now. And then you hear other things like, well, recruitment is most difficult, JJ, we can't do that. So that's why we did it. Some have even tried to sell me on the idea that it's better quality and better services as a result of that. And those folks scare me. So today we're going to talk to Harold, and he's here in the studio to talk to us a little bit about his perspective and insight as not only a thought leader in this field, but also someone that has spent 20 years, 2 decades, researching information about how hospital payment and reform and quality and all those programs fold up into the organization of the hospital and the success of those hospitals and programs that are specific to those hospitals, such as maternity care. So we'll talk about staffing models, insurance plans, and of course, what all this has to do with rural health. So it's great to have Harold back in the studio again for that. So, why don't you let's jump right into it, Harold. Give us an overview of the loss of rural maternity care across the country.
Well, when you say you're hearing about this frequently, it's not surprising because over 100 rural hospital maternity units have closed in the past 5 years. That's 2 every month. That's a pretty remarkable number. And it's a big number in a number of states. Indiana has lost 12. Ohio has lost 8. Wisconsin, Minnesota, other states have lost many hospitals. Maine has lost 6. And in some cases, that's a huge proportion. Indiana and Maine have both lost 1/3 of the maternity units that were open just 5 years ago. And what that means is that in those many communities, mothers are now having to travel 30, 40, 50 minutes or even more in some cases to deliver their babies and even to get prenatal care. And fundamentally, what that means is that we're going to start seeing more and more babies delivered by the side of the road. And unfortunately, we're going to start seeing more and more mothers and babies dying because they couldn't get to care sufficiently quickly. We're now down to 42%. Only 42% of the rural hospitals in the country are still delivering babies. And one of our concerns is that this isn't over yet because the majority of small rural hospitals around the country are losing money overall. And if you're losing money overall and you're trying to stay afloat, you have to look for things that you can eliminate. And if you have a service line that also is losing money, like maternity care, that's what's leading a lot of hospitals, I think, to be forced, even if they want to keep it open, to eliminate it. And I think we need to start working right away to try to fix that before we lose even more hospitals.
Harold, great perspective. Interestingly, I had a major hospital system executive in my office several months ago. And I took him to task on, they had shut down 2 of their OBs in a region that adjoins mine somewhat. It's in another state. And I got to be honest with you, Harold, I can't even describe the atmosphere in the room because it turned to, JJ, this is better outcomes for patients. Carol, do you think they believe this? Do you honestly think that they believe that there's better outcomes by having moms drive 50 miles down the road to receive care? What in the world? And I know it's a rhetorical question, but I mean, you've seen a lot in your career, but this level of misinformation and justification is very dangerous.
Mm-hmm. Well, I think there has been the myth for a long time that bigger is better and that somehow only big hospitals can deliver good quality care and only large physician practices can deliver good quality care. And there's absolutely no evidence for that. But the belief, and I think of it as a unfortunate urban and middle class bias, is that, well, if this hospital closes, you can go to a bigger hospital. And somehow, it's not that bad if you have to go drive a half an hour. Well, I don't think that most of the people who say that have ever actually been in labor.
Exactly.
And wondering when the baby's going to come. And babies don't exactly predict when they're going to arrive. As Rachel, your former colleague, said in a video talking about the experience that she had, is that if she wasn't able to be at Hillsdale Hospital, she could have died. And I think a lot of people don't appreciate the fact that even though in the vast majority of cases, women have good outcomes in terms of their pregnancies, that in an unpredictable share of them, even in low-risk pregnancies, problems arise. And if you don't have available services to be able to deal with that quickly, you could literally have people die as a result of that.
Absolutely. Your article recently on LinkedIn, and I did see where Rachel commented underneath it, really is gaining a lot of attention and awareness. And Harold, that's what I appreciate the most is, you're a voice out there. You're not an OB-GYN, so it's not like you have a vested interest in this. You're a community member that understands the value specific to rural areas, but across the country, regardless of rural or not, about OB and the services that are needed in the communities. And so I want to just thank you for, the work that you've done in that area. But it did, I read the comments, they're all very positive, and it's a lot of this. Really? That's going on? There's almost a denial that was existing. And then some of the discussion led to, all right, but what doctor wants to come to a rural community to practice? And so what we're experiencing right now is in communities that are very, very rural, is the issue of staffing models, both on the OB side, in terms of the nursing staff and the labor, as well as the providers, the OB-GYN. And we're hearing more and more of that. We know of the shortages that we're going to experience with physicians by 2030. We've heard about all of those things. I guess, maybe from your perspective, because I get lost in this vacuum here at Hillsdale, talk to us about what you're hearing about innovative ideas and ways that you're seeing existing labor and delivery units implement to address some of the staffing issues that are a major concern.
Well, part of the problem is that the way things were staffed in the past don't work as well as they used to. Traditionally, you would have a group of OB-GYNs who delivered babies at the hospital. And because that's a 24/7 service, you have to have physicians on call 24 hours a day, 365 days a year, in case a baby is about to be born or there's a complication of pregnancy. And the challenge is that means that those physicians basically have to be, available nights, weekends to do that. And many physicians, like the rest of us, have children and families and don't want to be, away from their families delivering babies, at night and on weekends all the time. And they certainly don't want to do it, which is what the traditional role was to do that for free. That was the expectation, is that you have a group of OB-GYNs, they will get paid their salary, and for absolutely no extra compensation, they're going to be, up in the middle of the night and then still coming into work the next day to take care of people. And that's just not as easy to get people to do that anymore. And particularly the problem is in rural areas is that you have a smaller number of babies, so you need fewer physicians, but you still need to have the 24/7 coverage. And with a smaller number of physicians, that would mean that if only they were providing that coverage, they would have to be on call, a significant proportion of the time. And if one of them leaves, retires or moves to some other area and the others are trying to pick up the slack, you may say that they're on call 50% of the time. That's very difficult to do. So a number of hospitals are, some places say, we can't find physicians, and what they really mean is they can't find physicians who are willing to work in that
to do that, yes,
old style model, and they either have to pay more to be able to get physicians to do that, or they have to move to a different model. There are some hospitals small rural hospitals that are converting to a laborist model, where they are contracting with physicians who come in to be available to deliver babies, and they're there for an entire week in some cases to be able to do that. Other hospitals have to contract with physicians to come in and cover those night shifts and weekends. And there are hospitals that are successfully doing that, but the challenge is it costs more to do that.
Mm-hmm.
And that cost, that on-call cost, that standby capacity cost, is increasing over time. And that's on top of the fact that the hospital has to have obstetric nurses available 24/7. They have to have anesthesiologists and nurse anesthetists available 24/7. And operating staff available in case a C-section is necessary. So the cost per birth is going up. And what we have seen is that health insurance plans aren't paying to cover that cost. So the hospital is faced with the issue of either they staff in a way that is feasible, but that costs more and they lose money, or they don't staff that way and end up having no staff to be able to deliver babies at all. So there are staffing challenges. There are different ways of staffing, but they are inherently becoming more expensive. And so I think people need to understand that is a reality. That is not simply people saying, we want to be paid more, or hospitals saying we want to charge more for the service. It's a reality that it's becoming more expensive, and we have to have health insurance plans pay that. Now, the criticism has typically been that that's a Medicaid problem, that somehow Medicaid isn't paying enough. And that is true in a number of cases, but it's also commercial insurance plans. And I think people have to recognize that even if they have commercial insurance, that commercial insurance plan in many cases is not paying adequately to support the cost of care in their community.
Harold, great point. Sadly, it does all revolve around insurance when it comes to reimbursements that hospital receives. Historically, traditionally, we do see that in rural communities. It's a higher rate of Medicaid in those rural communities, the poverty rate's higher. So you see a higher incident of Medicaid patients. And therefore, we know, historically, when we trace back, let's just say to 1991, we have not had an increase in Medicaid reimbursement in Michigan since 2001. So for 24 years, we have not had an increase. But at the same time, labor costs are rising, no pun intended here on this one. But, the cost of employment, physician contracts, now they want RVUs, now they want guarantees. A lot of challenges are encompassed there. And so to your point, when hospital administrators and boards are looking at, just from a cost basis, and they look at that bottom line, those programs such as obstetrics, such as psych services are often first on the chopping block. But we have to make sacrifices because I look at these as community benefits.
Right.
And I would rather have an investment in a community benefit for obstetrics than sponsoring the local parade or the local field events, and a lot of mixed priorities in that. There's a one hospital that closed their obstetrics not too far from here, went out and contracted and built a stadium in the state of Indiana for sports playing. Swear to God, true story. And so how do you do that? How do you reconcile? I can't reconcile that. If I'm going to do that much of community benefit, I might as well put it into those who need it the most and the least among in the community. So,
right. And I think traditionally there were a lot of hospitals that just accepted that they were going to lose money on obstetrics and then subsidized that with the profits that they were making on other services. But a growing number of, and this is particularly smaller rural hospitals, are not making profits overall anymore. And so if you're not making profits overall, not only can you not subsidize maternity care, you may have to figure out how you're going to either eliminate that in other services in order to keep the hospital as a whole afloat. And my concern in general has been, there's been attention to hospitals closing, but not nearly enough attention to the hospitals losing services. And the fact that the hospital hasn't closed doesn't mean that the community hasn't lost critical services. And obstetrics is one of the biggest and most challenging ones I think that we need to address.
That is a great point. So as we talk about insurance, and I see that as one of the areas that I glean the most from you and from your publications is really on in reform, insurance reform, and how do we pay for all these services? And so if you were to look at it, Harold, from your lens, how are we ever going to have true payment reform, though, to address some of these issues? Now we're hearing Congress and the bipartisan approach, they're fighting over what cuts to Medicaid are going to come in reconciliation. We hear a lot of conversation about they're going to get rid of the provider tax. That's how I get an uplift to be able to provide the services like obstetrics in my community, is that provider tax. So we're hearing about all of this. Can you give us an update, like what can be the outcome of this? I mean, it's not good.
Well, I think, first of all, there has to be greater awareness of first on the Medicaid side, what Medicaid is actually supporting. And there's been a lot of focus on who is covered by insurance, whether it's Medicaid or other insurance. There has not been enough focus on what the insurance is actually supporting, because because you have insurance doesn't mean that it's paying enough for someone to deliver the services that you need. And so I think that there's been a lot of concern about fraud and abuse in Medicaid, et cetera. There hasn't been nearly enough concern about the fact that it's not paying enough in many cases to be able to support these essential services. I think it's important to try to make sure that Medicaid continues to cover those it needs to cover and pays adequate amounts. But I am a little concerned that we're now so focused on trying to preserve Medicaid that we're taking the attention away from whether commercial insurers are paying adequately for services.
It's a good point.
And one of the other great myths that I've seen is that everybody assumes that commercial insurance is paying more than Medicaid. That isn't true in some rural communities. There are some small rural hospitals in some states where Medicaid is actually paying them more than the commercial insurance plans are.
Correct.
And just because commercial insurance plans are paying more than Medicaid doesn't mean that they're paying enough. And so in the case of labor and delivery, you're talking about typically around the country, about half of the births are Medicaid and about half of them are commercial insurance. So if both of those payers are paying inadequately, there's no way that a hospital can support that. And there's no way that it's going to be able to keep physicians or other staff there to deliver babies if they can't pay them adequately.
That's right. That's right, Harold. So you've been around for decades and have studied all of this function of government as it relates to, reconciliation and looking at health insurance, Medicaid and Medicare specifically. And I'm going to put you on the spot. If you had a crystal ball, where do you think this is going to lead us in the next few months? Do you think we'll have a unified reconciliation where Medicaid is preserved, and then that there's going to be an awareness towards the commercial insurance as well, or do you think it's just going to be overshadowed? What are your predictions? Could you help us out?
Well, I think it's clear right now that in terms of Medicaid, and Congress is becoming aware of the fact that there isn't automatically just $1 trillion of savings that you can achieve in
Right.
Medicaid with simple things that aren't going to hurt people.
Right.
So I hope that whatever reforms are made become more nuanced, and I think again this is a matter of whether or not people make Congress aware of this. Is that not only do they look at things that they can cut, but things that they can improve. And there has not been nearly enough attention to that. And so we may end up seeing something that is a better system for that. The provider tax on hospitals is a good example of that. I think there's been a lot of concern about how that's simply money laundering and it's a way, but many people don't realize that provider tax in many states is what is actually providing the funds that rural hospitals need to be able to stay afloat. I do think one of the challenges is that rural hospitals are not doing enough to be able to explain to people what their actual costs are and how they are supporting that. Many people are not aware that a lot of rural hospitals around the country are supported by local tax dollars.
Right.
A lot of people don't realize that states, through their Medicaid programs, are providing special payments, either cost-based payments or supplemental payments, to keep the rural hospitals afloat. And again, this is a bit of the urban bias, is that there's an assumption that all hospitals are funded in exactly the same way and cost the same amounts. So I hope that if more attention is delivered to that, it becomes not just a Medicaid solution, but we also look at how rural hospitals can be paid better by commercial insurance plans. Because if, in fact, people start to understand what it actually costs to deliver these services, and that plans are not paying for that, that hopefully we can get better payments from all the payers for that service, rather than simply trying to preserve or avoid cuts in one.
Yeah, incredible strategy, and in the simplistic form of just educating your community on what the costs are and what's associated with delivering those services. I think that's brilliant, and it's very simple. It's very simple to do.
The other thing that we need to do is we need to recognize that the way we're paying for maternity care right now, this is true in Medicaid and commercial insurance, doesn't really support the way the costs are incurred. We pay today based on a per birth basis. And moreover, one of the perversities of the structure is that we pay more for a cesarean section than we pay for a vaginal delivery. Yet we actually want to discourage cesarean sections.
Yes.
Which means that if a hospital actually successfully reduces the rate of cesarean sections, it will lose even more money.
Yeah.
And we need to be able to pay differently for that. And moreover, the hospital basically it's incurring costs because it has to have physicians, nurses, anesthetists, all standing by waiting for deliveries. It incurs those costs regardless of how many births there are. If there are more births or less births, the hospital's costs don't change that much, but its payments do. Yeah. So if it delivers fewer babies, and who can predict how many babies there are going to be in the course of a year? If there are fewer babies, the hospital will get less revenue, and that means the hospital will lose money. So what we've advocated for is that there ought to be a two-part payment, that health insurance plans, Medicaid and commercial insurance plans, should pay the hospital an amount based on the number of women in the community who are of childbearing age, not based on how many babies there are, but how many women there are in the community who are of childbearing age, and then a smaller amount per birth to be able to cover the actual out-of-pocket costs that occur whenever a baby is delivered. And that two-part payment system, would better match the way the hospitals actually incur their costs. There was legislation introduced in the last Congress to do that in Medicaid, to require states to have a program like that. And I'm hoping that that could be reintroduced and passed this year, because I think it would make a big difference in terms of, for many hospitals, and their ability to continue to deliver babies in the face of all of the other things that are going on.
Great perspective, Harold, and true to the point. Hopefully Congress will take that back up and maybe even look at it as a way in which to have a good return on investment for the decisions that they're making right now, to try to look for ways that they can have efficiencies in Medicaid. And to your point, I think this could be one of them. So as this is a national podcast, and across the country, we have CEOs that often reach out to me and say, thank you for that perspective and thank you for that particular guest. Harold, there may be someone listening right now that's considering closing their obstetrics unit. And, trust me, it's crossed my mind. Okay. It really has. When times are very, very lean and you're looking at significant losses. But I didn't, and for all the right reasons, of all the patients that needed to. But for someone, listening right now, what would you give as a recommendation for how we can slow down these closures? I mean, is there a process? Is there a way? Is there a mechanism in place? And, ultimately by stopping that or slowing it down, rural hospitals can ensure the future of maternal health and good outcomes for their communities if they can do this. If they can't, then we know that it's going to be, as you indicated in your preamble, lots of death potentially, and we're not being dramatic. So how do we slow it down?
Well, I think it's important to recognize that it is a community service. It's not a business. It's not sort of, some proprietary thing that we need to keep secret, how it is we deliver babies and how we make that work. I think that it's a community service. And so the community needs to understand what's involved in being able to do that. What kind of staff do you actually need to be able to do that? And what does that cost? And what are we currently being paid for that? So employers in the community, for example, need to understand that. They need to understand that the hospital, if it costs a certain amount for the hospital to do it, it's not because the hospital is overcharging, charging some outrageous price, but in fact, they're trying to cover a cost that is fundamentally very expensive. And that employer needs to say, well, how is the health insurance plan that we're using for our employees covering that? Are they paying you adequately for that? And if they're not, then that employer needs to say to the health plan, either you need to change that or we're switching our health insurance plan.
That's great. Yeah.
And states need to ask the hospitals, so what's involved with that? So long before the hospital has to try and suddenly announce that it's closing its labor and delivery unit and then take all of the criticism from the community for having suddenly surprised them with this removal of the service, I think they need to get the community engaged earlier on in recognizing that keeping it open is everybody's job.
That's right.
If the hospital is truly a community institution, then it's everybody's job to help that community service stay open, and everybody needs to do what they can to be able to make that happen. And one of the things that is involved is making sure that the payments are adequate for that.
Harold, we could talk to you for hours, really. I mean, the wealth of information that you bring to the table in many areas. We could spend just a day on, payment reform. We could spend a day on, small rural hospital closure. We could spend a day on what's happening around the country with, maternal health. But, we're out of time, sadly. And it is always great to get your perspective, and always encouraging that you always can offer, as you just did, solutions that hospitals and executives can take to be preemptive, so that they're not on the firing line of their community saying we're closing the obstetrics unit, and then ask the tough questions at that time and to head those off. And I love the ideas and the suggestions you've given to our listeners today. So as always, I always appreciate your perspective. And, as we wrap this up today, we always really look at, how can we help others in rural communities across this country? And much of that isn't because I can talk about things. It's because our experts like you are on this program can give insight to our community leaders. And so I would like just to ask you, to give us a recommendation that you would have. You've been in the industry now for decades, and it could be, how someone new in healthcare is doing their job or should do their job. how they can, maybe some sage advice on thriving in a rural setting, because as physicians are getting ready to practice, they're asking themselves, do I want to be in a rural community? Do I want to be in an urban community? And for leaders have to ask themselves that question as well. And so would you have a recommendation, and we like to post these online separate from this interview, but is there a recommendation you'd give someone about healthcare right now in America as we're facing, and what recommendation would that be?
I think in general, hospitals and physician practices need to be educating the community about what they do and what it costs to do that and how they're being paid for it. And members of the community need to ask that question. Yeah. There's been a lot of focus in the country on whether people have health insurance or not. And there needs to be a whole lot more focus on whether that health insurance is paying adequately or not. So when people who live in the community, employers or individuals, are buying health insurance, they need to be saying, well, is this the right health insurance plan to buy, not just because of the premium, but is it actually going to support the healthcare services in the community that I need? And the people who deliver those healthcare services need to answer the question for those people who ask that. So which health plans are paying us appropriately to deliver high quality services and which are not? And I think that would help us to get back to a situation where both sides of the table, the providers and the payers, and the real purchasers, the community employers and the individuals in the communities, start talking to each other about what's necessary to provide sustainable rural healthcare, as opposed to everything going up through contracts and things like that. People individually need to understand that and then say, what do we need to do to be able to support that?
Mm-hmm. Great recommendation, Harold. I hope to have you back here in a few months to talk about maybe some great initiatives. Hopefully by then, Congress is a little wiser to the fact that 74% of Americans do not want Medicaid cut, and that hopefully there's an awareness, as you have indicated, that as they look at this issue from a different perspective or a different lens, they'll start to introduce some legislation that'll be very helpful to hospitals as it relates to Medicaid and other services, and then that payers will follow in suit of that, other commercial and payers. And that, to your point, that employers will start asking questions about coverage for their employees, and that hospitals will start asking questions about, how they're getting reimbursed. And then that trickles to the community being aware. All of this is so critical, and you brought a great perspective today to our listeners, and I really appreciate the time that you've taken today to share with us your great wisdom, and I do look forward to having you back again very soon.
You're welcome, and thank you for the invitation, and thank you for everything you do to raise awareness around this. So thank you.
Thank you, Harold. Look forward to seeing you again. Take care.
Likewise.
And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so that you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.